Oh, it's been a fantastic meeting and I've really enjoyed this IOF-ESCEO World Congress on Osteoporosis here in Krakow. Something I found particularly interesting was learning about how to establish new ways of estimating fracture risk and also how to communicate that risk to patients. As you know, there are well-established ways of estimating fracture risk, such as measuring bone mineral density by DXA and by the use of fracture risk calculators such as FRAX. But here at the IOF we saw some cutting-edge science on novel ways of assessing fracture risk. For example, Professor Serge Ferrari gave a plenary lecture on bone microstructure assessment through HRPQ-CT scanning and fracture risk and how this has some implications for the clinician. He presented a really wide variety of studies demonstrating that poorer cortical and trabecular microstructure at the distal radius and tibia is associated with a risk of fragility fracture, and that this can be used to predict fracture independent of aerial BMD and FRAX. Of course, HRPQ-CT is only available in specialist centres and not particularly widely, and of course it doesn't measure BMD at central sites, but where it can be used, it can be used to assess imminent fracture risk and can be useful, and maybe will be particularly useful in the future and in research projects. Moving on to something that can be performed more readily in clinic, Professor Nicholas Harvey discussed functional assessments using a subset of the Mr. Ross study, which comprised around 7,500 older men in Sweden, Hong Kong and the USA. And through this study he demonstrated the value of a mobility assessment in assessing fracture risk. He demonstrated that measures of muscle mass and chair stand time and walking speed could be used as independent predictors of fracture risk and perhaps may be incorporated in future in our assessments. And also that these associations remained largely significant after adjustment for FRAX. So that's an important finding. Moving on to something more biochemical, we learned about bone turnover markers from Professor Eugene McCluskey, and he showed that several studies have demonstrated their value in fracture prediction. And through some recent research, he demonstrated that in a population of older women, baseline serum CTX predicts incident hip fractures, and he showed that this was important in terms of predicting fracture independent of FRAX probability, although this was attenuated a bit by adjustment for femoral neck BMD. We also had a plenary from Peter Abeling, and he gave some interesting insights into the importance of thinking about a patient's BMI, particularly obesity, in the context of fracture risk. And he discussed the patterns of fractures that an individual might be at risk of if they're obese, and also the awareness of sarcopenic obesity. He talked about the role of visceral fat and intramuscular adipose tissue on muscle strength and bone microarchitecture, and also demonstrated the role of bariatric surgery in increasing a patient's fracture risk and the need for this to be part of bariatric surgery care, as this is something that's happening more commonly. And then finally, on a practical and clinical level, I really enjoyed a session by Dr. Kasim Javed and Prof. Serge Ferrari alongside a health psychologist who conducted a really brilliant session on how we can best describe fracture risk to patients, as telling a patient about their 10-year fracture risk is quite an abstract concept and hard for patients to grasp. So we learned through this session how to make what is an invisible disease, osteoporosis, more visible and understandable to patients, and also to make fracture risk clearer to patients through a different and more interactive consultation approach. So that's something that will be extremely useful to the clinicians attending. So yeah, to summarise, this IOF World Congress on Osteoporosis has provided new insights into fracture risk prediction and has provided me with some new approaches I can use clinically to communicate this risk to patients.